Okay, well, why don't we get started? Welcome to the SADS Foundation's 8th webinar in our Living with SADS series, this one on long QT syndrome type 5. I'm Marcia Baker. I'm the program director for the SADS Foundation. Before beginning the webinar, a couple of reminders. You all entered on mute, and I want to advise you, please keep yourself muted during the presentation just to improve the sound quality for everyone. Following the presentation, we've allotted plenty time for questions and answers. And you may type your question in the chat box anytime during the presentation, and we will address those questions at the end. Our webinar is being recorded and may be accessed later on the SADS Foundation's YouTube channel. And now I'd like to introduce our speaker, Dr. Yukiko Asaki. Dr. Asaki is a pediatric electrophysiologist and an assistant professor of pediatrics at the University of Utah, Salt Lake City. Her clinical interests include arrhythmia and antiarrhythmic management, radio frequency and cryoablation, and pacemaker and implantable cardioverter defibrillator management. Her current research is in inherited channelopathies and sudden arrhythmia death syndromes, as well as pacemaker and ICD outcomes and management. Yuki received her medical degree from Mount Sinai School of Medicine. She completed her internship and residency at Dartmouth Hitchcock Medical Center. Her fellowships in pediatric cardiology and pediatric electrophysiology were both completed at Texas Children's Hospital, Baylor College of Medicine in Houston. Yuki was recognized in 2019 as the clinical award recipient of the SADS Foundation's Young Investigator Awards for her research on long QT syndrome type 5. It's now my pleasure to welcome Dr. Akiko.
Thank you.
Yukiko Asaki. I'm sorry, Yuki. Go ahead.
2 first names and 2 last names somehow.
I know. And I have a Japanese niece named Akiko, so I keep mixing it all up.
Well, hi, it's really nice to be here. And Marcia, thank you for such a nice introduction. And thank you for giving me the opportunity to talk a little bit about long QT type 5, which we are fortunate to know a little bit more about now than in the past. So it's still a little bit kind of hot off the presses to talk about. So thank you guys for coming and for your interest. So we'll just kind of go through and kind of get started. So mostly what I'm going to be presenting are the result of this large study that we had just completed. You can see that the number of authors here almost doesn't fit on the page because it was a very large multi-center study that incorporated many centers across the world. And as a result, this is the largest cohort of patients with type 5 long QT syndrome in published history. And so we know a lot more about type 5 long QT syndrome as a result of this project. So I can go through what we learned. So just a little bit of background in terms of what we're talking about when we're talking about long QT syndrome. In general, we are trying to correlate electrical occurrences on a cellular level, which are represented by the action potential on the upper tracing, with electrocardiographic tracings that we can observe clinically, which are on the bottom tracing. So essentially, when we look at all those squiggles on the ECG and we're making all the measurements that include the QT measurement as one of them, what we're doing is we're trying to correlate what's happening on a cellular basis. And that is the electric background for long QT syndrome of all the different types. So when I move my mouse, can you actually see my mouse moving? Okay, great, that's perfect. So in general, when we think about the action potential at a cellular level, we're thinking about electrical depolarization in this red line here, which correlates to the main QRS spike on the ECG. And then all of electrical repolarization, which is divided into a couple different phases depending on the channels that are involved, the ion channels that are involved, that correlates to this repolarization time on the ECG, which is the ST and T wave segment. And so when we're talking about long QT syndrome, we're actually measuring the entirety of this action potential from the depolarization to repolarization phase, which, since we can't measure on a cellular basis in humans, we look at the ECG tracing, which is representative these cellular action potentials. And so the QT measurement is the entire QRS, and ST segment complex that we measure. So in the action potential, there's a lot that's going on. And so you can see each one of these little channels and these circles are starting to represent which ion channels are open during different phases of the action potential, the direction of ions that are flowing, and sort of how it correlates to this shape. And this is not something that I think is worth spending too much time looking at, other than just to kind of recognize that this is why we have so many types of long QT, is because a mutation in the gene that codes for this channel will give us a specific syndrome, and it'll be different from the syndrome caused by mutations in the gene that codes for this channel, different than this one, and so on. So you can see that with all these different types of ion channels, and then these are the currents that flow through these channels, this is why we have so many different types of long QT syndrome. And so in fact, currently there is some discussion about whether or not there's actually a 17th subtype that's been described, but overall you can see that there's quite a few different types. Overall, in terms of patients, the number of patients out in the world with long QT syndrome, long QT types 1, 2, and 3 make up the vast majority of known patients with long QT syndrome. And so some of the rest of these are relatively minor contributors to the overall field of patients with long QT syndrome. However, I think that for a family member, if you have a family member or you yourself have one of these conditions, then it's 100% of the people that you care about. And so it's not as important necessarily in the global sense, whether or not it's a common or less common subtype of long QT syndrome. But it does make it a little bit harder from a knowledge base and from a provider perspective to know exactly the right recommendations for some of these less common forms of long QT syndrome, since there's just not as many patients affected by it. And so we can't say with as much confidence all the time what will be affected and what to expect with living with the condition. So we wanted to look at long QT type 5. And because it is such an uncommon condition, we wanted to kind of compare what we thought we might know about it, some guesses that we can make just based on knowing how the channel that's affected would change with the pathogenic mutations that are involved in long QT type 5, and then actually trying to develop the largest cohort of patients that we could find of patients that did have type 5 long QT. So to talk a little bit just about what we thought we might expect, this is a channel that is encoded by the gene called KCNQ1. And KCNQ1 is responsible, mutations in KCNQ1 are responsible for type 1 long QT syndrome, one of the most common forms of long QT. And so mutations in KCNQ1 that affects this channel itself, and can prolong the amount of time that it takes to repolarize as a result of changing the current through this channel. So long QT type 1, we know a lot about. And so we thought possibly long QT type 5 might have some correlation with long QT type 1, because the mutations involved in long QT type 5 are in KCNE1, which encodes for this regulatory subunit that interfaces with the channel encoded for by KCNQ1. So we thought, because these two, we sort of call this the alpha subunit, and then this in KCNE1 is the beta subunit, which is a regulatory subunit. So we thought possibly patients with long QT type 5 might behave clinically similar to patients with long QT type 1 as a result of these two, this subunit of this channel being affected, as opposed to any of the other types of long QT, which involve a completely different ion channel. So the majority of patients with clinically described long QT type 5 have one specific mutation. And this kind of came up during the discussion, is that we're taking a pretty rare condition, mutations in KCNE1 we don't have that many patients that we know are affected by mutations in this gene to begin with. And then how do we manage kind of the most common form of that pathogenic mutation versus some of the other rarer forms? So in order to gather as big of a cohort as we possibly could, we wanted to create a registry of all known patients with long QT type 5. And it really was, and it was a little bit of an ambitious goal that we set out, but we really were interested in trying to capture every single known patient with type 5 long QT syndrome in the world. And part of the reason that we were even dreaming as big as we were with that goal was that there aren't that many patients in the world. There's a cluster of families that tend to be affected in different parts of the world, but it's not such a big number that we thought it would be completely impossible to find. And almost all of them are cared for at large academic centers. And so if we could contact enough of those centers around the world, then we could potentially create a very large, robust registry. And so that's what we set out to do. We ended up, I think it was 22 centers across the US, Canada, Europe, Asia, and Australia. So to be included in this registry, we had patients that had either a known pathogenic or suspected to be pathogenic variant in KCNE1. The presence of that, or they either had the genetic background or they had a phenotypic presentation where they had a KCNE1 variant, or we did not actually know if that was pathogenic or likely pathogenic, but they had manifested a phenotype, meaning that the QT interval was prolonged. These measurements are all in the long, would characterize something as being a long QT, and they had this variant of unknown significance in KCNE1. With those patients, we collected as much demographic information as we could get in terms of the patient's age, the patient's clinical history, in terms of what tests they'd had, treatment approaches they tried, and then as much genetic information as we could gather for each patient. And then we started to evaluate that genetic data as best as we could. And I'll get into some of that. I won't get too much into the weeds with this, but I will talk a little bit about why we thought it was important to look specifically at the different subtypes of variants that we found. So let's dive in just a little bit. So of the total cohort, we had 19 patients that had a KCNE1 variant that also had sensorineural deafness. And so this is a very specific subtype of any of the long QT forms, in which is called Jervell-Lang-Nielsen syndrome. And they tend to have a very severe form, and they tend to have a more homozygous, meaning that they have both copies from both parents. And so we were interested in this cohort, but because they're a very minor subset and they have a very different clinical phenotype, we excluded them from the majority of our analyses, and we looked at them separately. So for patients that had classic long QT type 5, we found that was a total of 242 patients across all of these centers. So even with such a large cohort, such a large collaborative effort to create this registry, we were still not finding a ton of patients, which is reflective of just how uncommon type 5 long QT can be. In this cohort, we found that 95 out of those 242 patients were the proband, meaning that they were the first patient in their family to present to clinical care. And part of the reason that we were interested in that is that often the probands were presenting with a clinically significant episode that may be suggestive of more severe disease. And then subsequent to the proband's diagnosis, that often prompted cascade screening amongst other family members to see if anyone else in the family carried the same variant and were at risk for these conditions. And so those made up about 147 members of our cohort. So it was approximately 1/3 probands and 2/3 family members in terms of how they presented to care. So we started to look at what are the differences between those that were diagnosed as the proband and the affected family members that were diagnosed as part of this cascade screening. And I'll just kind of go through this table to talk about what were there differences in any of these parameters between whether or not you were diagnosed as the proband versus whether you were a family member. So the QT interval themselves, we did find there was a difference, that it was longer in the probands compared to their genetically affected family members. There is a difference there's probably a role of estrogen in the role of the length of the QT. So we don't always compare we don't always think that comparing male and female patients with long QT is completely apples to apples. So we broke that down to look at males with long QT type 5, and we found that they also had longer QT intervals compared to their genetically affected male relatives, and that females also had longer QTs if they were the proband compared to their family members. We found that there were more patients that were the proband that were treated with beta blockers during the course of their care. And we found that more probands had an ICD implanted at some point during their clinical care. We did not see that there was a difference between probands and affected family members in those that received what's called a left cardiac sympathetic denervation, which is a surgery that's designed to minimize the neurologic input into the heart. This may have been just because it was a fairly uncommon procedure in both groups, but we did not see that there was a difference between probands and family members. In terms of syncope, which was determined to be cardiogenic in nature by the referring provider, we did see that there was more episode of syncope in the probands. And in terms of those who received an appropriate ICD shock, if you had an ICD implanted, we did not actually see there was a difference between the probands and the affected family members. They had an equal number of ICD shocks. There was a higher incidence of aborted cardiac arrest in probands compared to their family members, but there was not an increased difference in completed cardiac death, that they were not resuscitated, sudden cardiac death between the family members. So overall, what we saw in this picture was that probands indeed were more clinically affected by both the phenotype, meaning that they had a long QT, as well as these clinical episodes that were concerning. We saw that in general, while there were a couple, there wasn't complete straight yeses across the board, in general, they were more clinically affected than their genetically identical family members. So when we start looking at these cardiac events, we realize that there's so many factors that could influence someone. We're focusing a little bit on the genotype, meaning everybody in this cohort has type 5 long QT syndrome, but there are many, many other contributing factors that may influence whether or not someone clinically has an event. So what kind of cardiac events are we thinking about? We specifically were interested in syncope or fainting, appropriate ICD shocks, aborted cardiac arrest, and sudden cardiac death. But what's challenging about using this as a composite endpoint, meaning that we wanted to see if patients had any of these events together, is that sometimes with fainting, it's a little bit hard to know from a reviewer's perspective, meaning that we were not the primary clinician caring for that patient. It's a little bit hard to know all the time whether or not that fainting episode was as a result of an arrhythmia, or if it was a result of any of the other reasons that we might faint, of which there are multiple ones. So we completed our analysis to look at this composite endpoint with all 4 of these clinical endpoints, but we also looked at it without syncope. We would remove syncope so that we were looking purely at the proven events that we know were definitely attributable to either an arrhythmia or to most likely to an arrhythmia in long QT type 5. So for the majority in the paper, if we were to go through all of them, we actually completed this analysis using both endpoints, but I'm going to focus on this endpoint for our talk just because it is the cleaner of the two, where we know for sure that this is an arrhythmic event. So to look at this composite endpoint, these are called Kaplan-Meier curves, which means that if you're not super familiar with looking at them, they can look a little funny, but we're looking at the age of the patient here, and then what percentage of the patient from 0 to 100 reached that composite endpoint, meaning at some point in their life, did they ever have an ICD shock? Did they ever have an aborted cardiac arrest event? Or did they die suddenly, ever? And as soon as you reached one of those events, then we go from a 0% up to 1 to 2 to 3, that kind of thing. And so you can see that these curves kind of in general go up over time. And we're comparing between the red curve, which are the probands, and the blue curve, which are their genetically identical family members that were identified as the result of cascade screening. So you can see over time that these curves start to diverge and that the red curve, the proband curve, gets much higher than the blue curve. And so when you run the statistical analysis, you can see that there is a significant difference between whether or not you ever reached one of those endpoints, ICD shocks, aborted or completed sudden cardiac death. If you were the proband, much higher likelihood that you would have one of those than if you were their genetically identical family members. We broke it down again by looking at the males and females in our cohort, and we saw that there was really no difference. NS means no significant difference. That you would ever reach this composite endpoint of having one of these events. Men and women had approximately the same number of events over time. We were very interested in whether a beta blocker would decrease the likelihood of any of these events, because our goal is to find the most appropriate treatment. And we know that beta blockers can help patients with long QT type 1 syndrome quite a lot. And long QT type 1, as we were sort of discussing in the beginning, we thought was the most similar of all the types of long QT syndromes that had been described, given the relationship between the channel and that's affected in long QT type 1 versus type 5. So we looked at patients that had been on beta blockers to see if it decreased the likelihood of having any of these events. And unfortunately for both endpoints, we did not see that beta blockers were beneficial, which was disappointing for us, given that we have so few effective treatments, and we were hopeful that beta blockers would be effective to decrease these events, but it seemed that they did not. So then we started to look a little bit at the genetic information. And the reason that we're interested in the genetic information is that we know that many, many forms of long QT syndrome, as well as a lot of other conditions, exhibit something called penetrance. And what we mean by penetrance is, if we look at this diagram and we say, okay, the capital B in this purple color means that you have the condition, and this lowercase b in this white bubble means that you do not have the condition. And so if someone with a condition and someone without have a baby, then you get one gene from each side, and you end up with someone that has a mixture of genes from both mom and dad. And so that can turn out in a couple different ways. If you imagine that each of these, dots are a possible baby that could come from this pairing, then in one condition you have a mixture where this genetically identical group, where you have one gene for the condition and one gene that is normal, results in some patients that have the clinical disease and some that don't, even though they have the exact same genetic background. And so we call this idea penetrance, that some people manifest the clinical phenotype and some people don't, and there's not just the genes that determine whether or not they do or not. This is sometimes included with this concept is a related concept called expressivity, which we see is kind of demonstrated by the shade of how dark these colors are. So maybe in this case, everybody has the condition, but some people are more clinically severe forms of it, these dark colors compared to the lighter colors. And then you can mix the two, where you have it or you don't have it. You can have a mild form or a more severe form. And all of this is occurring despite having identical genetic background. And so we're quite interested in this concept of penetrance, because we want to know, is the genotype the entire story? Are the genes that we carry 100% of the story, completely determinative? There's nothing else that influences your clinical picture that you'll have, or is there more to the story? So we found in this study that patients with type 5 long QT syndrome had a 21% penetrance, meaning that only 21% of patients that had these variants in KCNE1 actually had a long QT. And so this was very important to us, because we were interested in knowing, okay, 21%, just for what it's worth when we compare it to other conditions, is a very low penetrant percentage. Most other conditions have a higher incidence of having the actual clinical disease if you carry the genetic background for it. So when we combine that, we started thinking about that. They said, that's interesting that it's such a low penetrant condition. So then we wanted to compare that, and this is the weeds part that I'm not going to get too deep into, but we wanted to compare the frequency of some of these variants to the frequency of KCNE1 changes, variants in KCNE1 in very large genotype. Sorry, I turned on something. I apologize. I have to turn this off. Really fast. There we go. But we have very large reference genomes where groups would take thousands and hundreds of thousands of healthy volunteers and get their genes. And so then we have these large databases where we can say, okay, we have a patient with a change in their KCNE1 gene. We don't know the significance of this change. We have personally never seen it described as being disease causing. Everybody has a few changes as we all, as the generations pass by, the genes will often have slight changes to them. Is this change clinically significant or not? And so we often compare the frequency of these changes to these large reference gene reference databases that we have. And so when we did that, we compared the prevalence of KCNE1 variants in our population, and we saw to these reference databases, we saw that there was an incredibly high incidence, 238 times higher. We saw that our variants were there more frequently than you would expect. And we did that based on some math of how frequently we thought, how prevalent long QT type 5 would be in the world. And so we said, okay, this seems crazy that we have something, that we have such a low penetrance, that there's so few patients with a genetic background that actually manifest the disease. And the incidence is so much higher than you'd expect it to be based on the genetic frequency in the population. What does this all mean? And so together, what we thought that that meant was that having a change in KCNE1, having a variant in KCNE1 was not enough to give you type 5 long QT syndrome. You have to have something more that's happening, either environmental or another genetic influencing factor in your body that causes you to manifest type 5 long QT syndrome, and to actually have the clinical picture where you have a prolonged QT and you are at risk for arrhythmias and sudden death. And that is probably why we saw probans have such a higher incidence of, they had longer QTs and they had more clinical events. It's because they were the unlucky ones in their family. If everyone had the same genes, they were the unlucky ones that had some other factor that additionally contributed to their condition developing. And so that's why we were so interested in these genetic stuff. So to kind of sum up everything, we saw that the probans had longer QT intervals and they had more clinical events relative to their family members with identical genes. This means that the probans probably have something else going on that's compounding on top of their KCNE1 mutation. We saw that there was a low clinical penetrance of KCNE1 variants, meaning that not everybody that has the genotype has the clinical disease. And it was a much higher than anticipated prevalence in these reference genome databases. And so that means that probably just carrying the variant alone, if you don't have any of these other factors that are contributing, probably you're at low risk for sudden cardiac death. And that's it. That's kind of that was what I was thinking. So that is what we found overall in our large registry of patients with type 5 long QT syndrome.
Thank you very much, Yuki. Let me ask if anyone has questions. They can either unmute themselves and ask it verbally or put it in the chat.
I hope that wasn't too horribly wonky.
I learned some things myself. I appreciated hearing your research.
Well, I like to present, what we found, but also kind of why we thought it was meaningful, And I think that it's easy to just come up. I could just have one slide and say, KCNE1 variants aren't that disease causing, and sort of that be the end of the talk. But then there's not much to discuss. So we kind of wanted to show why we felt that those were meaningful findings.
Exactly. Let's see, Genevieve comments that thank you very much for the information. We have a type 1 and type 5 in our family, so this was very interesting.
Yes.
And Linda
Can I
asks,
say one thing before you move on?
sure.
I would say that that's not an uncommon situation, that I take care of several families where there's different variants coming from different kind of wings of the family. And it can be very challenging to know what's going on. And I think, you know, as a pediatric electrophysiologist taking care of the kids that are affected, I will sometimes see that family members can really struggle sometimes. If they have different clinical courses and some people feel, you know, why was I the one that drew such a short straw that I'm so much more affected, and my cousin can run around and you know, play, and I have to have an ICD or whatever the kind of changes are. And then the opposite, kind of a little bit of almost survivor's guilt, that they sort of feel badly that they're you know, nobody's done anything wrong, everybody's just you know, living their lives, but they have an easier course of it. And so I think that's one of those are things that we are not capturing, I think, in studies like this, for just how challenging it can be to navigate that as a family.
Exactly. So Linda asks, what do you think the triggers are for type 5, such as exercise or medication?
That is a great question. We did try to, I didn't include it in this study, but we tried as best as we could to find if there were triggers like that, like exercise or medication, that type of thing. The short answer is that we because it was a retrospective study that we're pulling from so many different places, it really depended on the quality of the record keeping at the time. And so we didn't have as robust information as we would have liked for all of these events to know exactly what was going on with the patient leading up to them. We did see that about, I'm trying to remember, and I hope that I'm getting these numbers right, but I think it was about a third of events occurred with exercise, which is lower than, if that number is correct. I mean, the caveat being that we're sort of not gathering as much information as we're missing information with these. But if that information is correct, that is lower than you'd expect for type 1, long QT type 5. If we thought that 5 was very similar to 1, which has a very high affiliation with exercise. And so we did see that there were a lot more episodes at rest, which we don't know if that means that they are more at risk at rest, or if we're just at rest a lot. You know, we're not exercising as often as we are resting. We didn't quite know what to make of that. It does seem that that QT prolonging medications in this group did have an effect, meaning that as you may expect from other types, you take more medications, you take higher doses, you take you know, a longer course, it's going to have a bigger effect on your QT. We did see that, but not enough that we could run statistics on it. So that's why I didn't include it in the talk. But we saw that as a trend for sure.
Thank you.
Yeah.
Any other questions or comments? Genevieve commented, I appreciate your acknowledgement of the difficulty with the different clinical courses. We have experienced that in our family. Thank you, Genevieve.
You're not alone. I can tell you that other families for sure struggle.
Okay, well, if there aren't any more questions, I thank everyone for participating tonight. And thank you, Yuki, for a wonderful presentation. And we will talk to you all later. Hopefully have a great evening, and we'll see you soon.